Thanks everyone for joining tonight. I'm really excited to talk about trauma-informed care, to kind of go into the basics and the general overview. So this is the presentation outline. I'll do some introduction into who I am, and then we'll get into the basics of trauma-informed care, which is first looking at what is trauma, what are the effects of trauma, and the basic principles of trauma-informed care and bringing them into your practice. There's also a little section on vicarious trauma for healthcare professionals, and some mention of practice traps of trauma-informed care, or ways that we might veer off course when we first start and continue using trauma-informed care. And then there'll be time for questions at the end. I also will have my email, and there's that little Q&A section here where you can ask questions. So my name's Jazina. I'm Lekwungen First Nations, which is called Songhees First Nation in English. That's located in Victoria in British Columbia, and I'm also Dutch. I currently live and work in Treaty 6 territory, and I also studied on Treaty 6 territory at the University of Alberta. I graduated in 2020 from the U of A with my PharmD, and I've been practicing since then. Although 2020 was the worst year to graduate. I don't know if there's any other 2020 graduates here, but luckily made it through. And I'm also an artist. I create on lots of different medias, and that takes up a large portion of my time outside of work. This is where Songhees Nation is located, that little star there in Victoria. It's been moved around a few times, so not originally there, but that's where we are now. And at the bottom, you can see our community center, which is kind of the hub of my nation, where we have our education, health, chief and council, gym, and where we go together for community. And so this is what Treaty 6 is. I don't know if you have seen a map of Alberta and the different treaties that make up Alberta, but we're largely Treaty 6, 7, and 8. And here's Edmonton right in the middle. So before I start talking about trauma-informed care, I wanted to talk about my journey with trauma-informed care and how I came into this concept. So when I was in school and even before school, I often had a lot of people that would look to me for guidance or ways of going forward about Indigenous healthcare. So my colleagues and other people in my professional circles, they would say, well, how do we provide better Indigenous healthcare? How do we improve Indigenous health outcomes? And when I was kind of going through my degree, learning about healthcare, learning about all these things, it was actually really confusing for me that a lot of people were asking those questions, because it was more like the healthcare is not different. Diabetes care is diabetes care. It was like people were looking for something more on top of the actual, pharmacology of medications and how we treat medical conditions. And I was struggling to find the words to describe what that extra something was to improve health outcomes. And then I had come across this concept of trauma-informed care, and it really seemed to give words to kind of this more balanced idea of healthcare, because the physical health remains the same. Trauma-informed care allows us to look more closely at spirit, mind, and emotions. So before we can get into trauma-informed care, we obviously have to know trauma. I think a lot of people know, overall what trauma is. There's many different definitions of trauma depending on where you look at. So any different dictionary might show you what a definition would be. Oxford says a deeply disturbing or distressing event. If we look at AHS, which is the Alberta Health Services here, they've got modules, and it says anything that threatens an individual's health. I personally like the BC Trauma-Informed Practice Guide, where they simply define it as experiences that overwhelm a person's capacity to cope. And to make matters more complex, there's even further subdivisions or dimensions of trauma, and again, multiple definitions depending on where you look. The BC Trauma-Informed Practice Guide lists out a bunch of different kind of subdivisions. The ones that I find to be most relevant when we're looking at Indigenous populations is we look at intergenerational trauma and historical trauma. So historical trauma is a cumulative wounding over a lifespan and generations that comes from massive group trauma. So that's things like when you think of residential schools, slavery, apartheid, things like that. And historical trauma then leads also to intergenerational trauma. So that's from living with trauma survivors. If we think of people who went to residential school and their families and the generations after, intergenerational trauma gets passed down. But trauma-informed care is not just relevant to Indigenous populations. When you actually look at the stats about trauma or post-traumatic stress disorder, the numbers are a bit alarming. 3 out of 4 Canadian adults can actually report some form of trauma exposure in their lifetime. So that is the majority of Canadians can understand trauma, and that could be any of your patients, not just an Indigenous patient that is coming to you with a history like this. And even 9.2% meet the criteria for PTSD. So it extends largely beyond Indigenous populations. So any patient could have experienced a traumatic event, and that may or may not have turned into trauma if it overwhelmed that person's coping abilities. And when we talk about historical trauma, I had mentioned residential schools. So as you know, we're in Indigenous History Month, and residential schools were one of the most devastating colonial practices that happened to Indigenous people, and largely a reason for the disparities in health outcomes, this mass drive to assimilate Indigenous people into the overall Canadian culture. So this residential school here actually is Cooper Island Residential School. That's the residential school that my grandfather attended. He also went to Kamloops Residential School. So that has been really difficult over the last year or so for my family, with all the media coverage about the residential school body fines, starting with Kamloops Residential School. But we would need a lot more time for a presentation to talk really about the colonial practices that lead to this trauma that exists for Indigenous patients. But I would recommend that this free course from the U of A, it's called Indigenous Canada. It's really great. I've taken it myself. I think it's about 12 lessons, really short. And what I love about it is it doesn't just focus on the trauma, it also focuses on a wide range of Indigenous art and community and knowledge. So when we look at what trauma is, then we start looking at how does trauma affect our patients, and why would we use trauma-informed care, and how would that show up? So there's various reactions to trauma. It's no one size fits all. There's some of the typical ones you might think of, depression, anxiety, self-harm or high-risk behaviors. But there's also other things that you might not think so clearly about when we think about digestive problems, or we think about the spiritual aspect of it, the loss of meaning or faith, loss of connection, feelings of shame or self-blame, self-hate, or interpersonal relationships where there's lack of trust or difficulty establishing and maintaining relationships, and constantly experiencing re-victimization, which is an important aspect of trauma-informed care. You might have heard of the ACE study, the Adverse Childhood Experiences Study. This was a large study based out of the US that looked at the association between these childhood indicators and later health and well-being. So it was a really important study to demonstrate that these 8 indicators of an adverse childhood experience does end up negatively affecting health later on in life, and seeing how that these traumatic experiences in childhood or development can lead to lasting impacts on all areas of health, including things that we might not think so much about, like increased injuries, increased chronic or infectious disease, decreased opportunities for people who have experienced trauma. And when we look back at historical trauma or intergenerational trauma, we can see here that at the very bottom of this ACE pyramid, Indigenous populations have experienced this historical trauma before conception. And overall, this can affect health throughout the lifetime, leading to a lot of these poor health outcomes in Indigenous communities that we see compared to the general population. So we've learned about historical trauma, we've learned about the resulting health gaps and the effects. So now what? What is there left for us to do? And that's where, helpfully, there's trauma-informed care that is an available concept for us to learn. So trauma-informed care is an overall way of working with people. It's not a specific set of techniques, although there are specific techniques within. Everyone can provide trauma-informed care, though. That's the important part. You don't have to be a trauma expert. When we think of trauma experts, we think of psychologists or addiction counselors. You know, maybe before you had not considered pharmacy as an area where trauma-informed care can be provided, but anyone can provide trauma-informed care. And trauma-informed practice or care is actually very broad. If you actually look at the BC Trauma-Informed Practice Guide, it's like, I think like over 300 pages long, because it's really such a broad and diverse topic. Really what we're going to be focusing on, though, are the principles, the basic principles. So trauma awareness, safety and trustworthiness, choice, collaboration, and connection, strengths-based and skill building, or what I call it strengths-based and empowerment. But when you really start looking deeper into trauma-informed care, you can see there's more, I guess, advanced skills like making links between trauma, mental health, and substance use with your patients, and building different skills. Often we don't usually have time for that in pharmacy practice, but the principles can be applied to any environment. So overall, these are what the principles are. As I mentioned before, the last one is empowerment and strengths focused. We kind of went over already being trauma aware, going over awareness here of trauma. So trauma-informed care begins with this awareness and realizing that pharmacists and other pharmacy professionals, really all healthcare professionals, have a potential to ease or exacerbate a person's capacity to cope with trauma. So the important thing is realizing that we have the potential to re-traumatize Indigenous patients, and Indigenous patients are often re-traumatized by the healthcare system. So realizing that we have the power to ease that by using trauma-informed care becomes really powerful. And there's lots of different examples, and we've went over a lot of them, realizing how common trauma is, how trauma can impact one's development, how people make maladaptations to cope and survive with trauma, the relationship between substance use, physical health, and mental health. And if we're even going further, we can look at spiritual health, emotional health, and also the devastating impacts of residential schools and other colonial policies to create trauma. Here's where we start getting into principles that we can actually use in our healthcare environments. So safety and trustworthiness is what I think is, of all the 4 principles, the easiest one for you to take away and to start using in your practice. It's the basis of making sure that we are not re-traumatizing our patients, which to me is, you know, our very first #1 step. So safety includes physical, emotional, and cultural safety, and it's central to trauma-informed care because trauma survivors often feel unsafe, have likely experienced abuse of power in important relationships as children or adults, and they may currently still be in unsafe relationships or environments. And just as kind of a prompt to be thinking about as I get into the next slide of example actions, but what are some ways that you might be able to build safety and trustworthiness into your practice as we keep going on? And some of them might be unique or not as obvious, but it's a really good question to reflect as you come away from the presentation. So I have some example actions here about ways that we could establish safety and trustworthiness. So for example, we could adapt the pharmacy space to be less threatening. I work in the inner city and I don't wear a white coat. That's a personal choice to, be less threatening and have less of a barrier between my patients and myself, to try and build safety and trustworthiness. I also have a lot of different pins on my name tag. I have my medicine wheel pin and other pins just to try and be a less threatening healthcare provider overall. Although I'm not very threatening to begin with, but the idea is we're trying to build safety and trustworthiness where we can. Another important thing that I think is sometimes overlooked in pharmacy is ensuring informed consent. And I know informed consent is in all of the guidelines for pharmacy professionals, but sometimes it can fall by the wayside if we're doing things that we've done a lot of times or comfortable with patients, or it's really good just to make sure that we check in and think like, does this patient have all the information about what is happening? And information might seem basic to you, but this person might have no experience with why you're doing things. So that's another thing, is explaining why we're asking sensitive questions. Because I work in the inner city, most of my patients do have some sort of substance use. Almost all of them are smoking cigarettes, and then a large majority, have marijuana, meth, opioid use, and a bunch of different other illicit substances. So I ask patients often what their substance use looks like. And what I realize is that without explaining why we're asking sensitive questions, patients can feel threatened by you. So often Indigenous patients have substance use disorders turned against them as part of a stigma instead of information collected for treatment. So I have women, for example, they're worried to tell me about the truth about substance use because they've had so many horrible experiences with child and family services. Or people have certain parole conditions and, they think you're going to call their parole officer and things like that. So explaining why we're asking sensitive questions, I just want to know this so I can see how it affects your medications. So I can see if there's any other ways that I might be able to help you. And even some patients, I go further and I say, well, this information won't be shared with anybody outside of the pharmacist, like the pharmacist or the pharmacy. So it's not going to be shared with any of these other people who they might be worried about. And other ways that we can also do this is to build safety and trustworthiness is to be predictable and consistent. That builds safety for everyone, is kind of providing a security. So demonstrating predictable expectations, being consistently trustworthy and empathetic to your patients. If you say you're going to do something, try to make sure to actually do it. For me, I'm really forgetful, so I have to write a lot of notes because I don't want to tell my patients that I'm going to do something and then I don't do it, because then I'm not building safety and trustworthiness with my patients. So safety and trustworthiness, I kind of find it to be like the keystone of trauma-informed care. Then we get into the next two principles, which are ways we can really expand our trauma-informed care to better help our patients. So the third principle is choice, collaboration, and connection. When we have a safe environment, naturally it fosters a sense of self-determination, dignity, and personal control for those who are receiving care. The main goal here is to level the power differential between pharmacist and patient and create a meaningful sharing of power and decision-making. So we're looking here for collaboration. We are moving away from paternalism in healthcare and working, to really have this patient-focused care, which is a concept that has gained a lot of recognition and popularity over the last little while. And it's important also to note for Indigenous people in the past, there's been a lot of restrictions in voice and choice for Indigenous people. So giving back choice is a really important step in our healthcare. And another question to kind of think about when we're talking about example actions on the next slide, but ways that you might be able to build choice, collaboration, and connection into your practice. How are you able to do that as it is now? And this is where we kind of get into more, maybe more complicated, although still a lot of these things are things you probably do already, and are simple in themselves. So we want to communicate openly. That helps us to build choice and collaboration. We're connecting openly with our patients. We're using open-ended questions for people to tell their story in their own words. Often Indigenous people have a completely different worldview that might not be captured by Western medicine or by most people's point of view. So open-ended questions really allow us to allow our patients to tell their own story. And it's important as well to allow that expression without fear of judgment and trying to, we are people that have judgment all the time, but recognizing that if we're going to be trauma-informed care professionals, that's something that we are going to work to keep to ourselves. And sometimes even challenge. And then we start getting into more of a collaboration with our patients. So we can provide choices as to treatment preferences, often for things that are not really that different. We can use shared decision-making. So for example, in smoking cessation, something simple as asking, patch, gum, inhaler. I mean, obviously coverage in the inner city dictates a lot of these things, but even just something as simple as providing, framing that as a choice instead of, assuming like the nicotine gum or the nicotine patch, really working to provide a choice and work collaboratively with our patients. And then we also want to do goal setting with our patients to determine the plan of action that they need to heal and move forward. So as we talk kind of later on about empowering our patients to make decisions that is for their healing and their health, that allows us to really level that power differential and give power back to our patients. Well, what are your goals? And a lot of times these goals might be different than a healthcare professional's goals. So because I work in the inner city, often there are things that are, high on the list of safety and things that are very important or would make huge health impacts for a patient, like quitting smoking, versus things that might be more important to a patient, like getting their blood pressure under control. It's like, well, if you were quitting smoking, your blood pressure would automatically be better, but this patient has no, energy they feel to quit smoking, but they feel like they want to put their energy towards managing their blood pressure. That's something that we can use for goal setting together. And then another thing that's important about choice is if someone refuses a medication or a test, or if they're upset about something like a vaccination, it's better to respond with compassion and try to work with that patient and see the barriers rather than attempting to force them or becoming annoyed. Oftentimes, Indigenous people in the past have had treatments that they've had no choice, such as forced sterilization for women in Indian hospitals and other situations. So sometimes these refusals may not necessarily be about the medication itself, just maybe healthcare in general. It's better to think about these different sort of ideas that might be behind refusal or being upset about something rather than assuming someone doesn't care about their health or they're just being difficult. And when we get into the last principle of trauma-informed care, we look at empowerments and strengths focus. So this is where we focus on an individual's strengths and experiences. We believe there's an inherent belief in the importance of the people being served and their resilience and their ability to heal from trauma. Pharmacists are facilitators of health and recovery instead of controllers of it. So again, it's kind of letting go of that control, letting go of that power differential, and working here with this principle to be facilitators of health and recovery, and really a strong partner with our patients in their healthcare journey. And as we go through again about some of the example actions for being strengths focused and empowering, just to think about some ways that you can be strengths focused and empowering in your practice. So this one is a bit more, it's a bit more difficult to get to this principle in the sense that a lot of this is belief-based. right? We're seeing here the belief of the importance of the people being served and their resilience and their ability to heal from trauma. So a lot of, racial biases or discrimination might come into play here, and things that you might, things that you might not even have thought yourself, things that have just been absorbed from society or living in Canada. This is where we want to think then about our underlying assumptions about the experiences of those with trauma, or and how people recover from trauma. So what are your beliefs about how people recover from trauma? Do you believe that people are kind of a lost cause when, they've got substance use disorders? Or do you believe that it's, willpower based, or that there's only one way to recover? How would this belief influence or work with others? And it's important to take a moment to really think about, if we're looking to be strengths focused and we're looking to empower our patients, we have to believe that there's a strength there. We have to believe that there's something to empower. And if you've ever heard of motivational interviewing, this is a really great technique to elicit behavioral change. And it's a great way to empower patients to make those changes on their own accord. So if you haven't heard of motivational interviewing, you've probably heard of like the smoking cessation scale. It's like on a scale of 1 to 10, how confident are you that you can quit smoking? On a scale of 1 to 10, like how important is it to you to quit smoking? And then you try to work with the patient to increase their rating on the scale until they're at a point where they can feel comfortable to make those changes. And this is where we brainstorm with patients. So what would bring you up from a 6 to a 7 on how important it would be to quit smoking? And this is how really there's so many different ways that we look at in recovery, and our patients can help guide us. And I feel as healthcare professionals, we can learn a lot outside of just what we normally might think of or normally practice. And then when we look at affirmations, we look at affirming our patients and their efforts and their strengths. We want to appreciate them. We want to try and offer understanding. We want to recognize success and even little success, because in the inner city, things are very chaotic for a lot of my patients. And it could be like their entire life looks like a mess. Like they're living in a shelter. They've got nowhere to eat. They've got no med coverage. Everything's messed up with their families or whatever else is going on. Like they've got a million health conditions. When we start to like break it down into little successes, and we're creative about that, this is where we can start thinking like someone who comes in for daily dispense methadone or Kadane, for example, at my pharmacy. Often I try and, recognize every day that they come in as a success. So prioritizing their health when they come in, that's what they're doing. They're choosing to come, they're choosing to be on this treatment, they're choosing to make a change, even if it's difficult. And even if patients fall off and, say they miss a day or they have to restart, we can still recognize the success that they are coming back to try again. And often I feel like everyone knows somebody in their life, not necessarily a patient, but somebody who's very doubtful of medications. Sometimes that can be frustrating, especially even personally, it can be frustrating. So we can try and reframe that in an affirmation kind of way to think, okay, well, this person, it's good that they're trying to be health literate on the medications that they're taking, or they just want to be sure that something is beneficial for them. And then that way, when we reframe things like this, we can start empowering our patients. So that's kind of the basics of the trauma-informed care principles. And when we look at trauma-informed care overall, it aims to treat people in ways that create emotional and physical safety. We want to give people choice and control over decisions that affect them in their health so that they can build feelings of control and empowerment. And as we give people more choice and collaboration and information, we can improve health outcomes in a significant way. So a note on vicarious trauma. As we were talking about before, trauma is common in all Canadians. So it's quite likely that, there are people on this call or people in your life who have experienced trauma or witnessed experiences of trauma. That's where we start looking at vicarious trauma and making sure that we're aware of it as healthcare professionals. So vicarious trauma or traumatization refers to the cumulative effect on the helper working with survivors of traumatic life events. So as I was saying, many practitioners have experienced or witnessed various degrees of trauma. And especially working in the inner city, for example, I'm exposed to repeated stories of trauma and abuse that my patients experience. And when we look at the effects of vicarious trauma, it starts to look a lot like burnout, and it really can have a lot of professional impacts, and not just in our work environments. It can spread into all areas of our life. So it can look like low motivation or avoidance, decreased productivity or apathy, tardiness, exhaustion, poor communication, conflict with staff, things that you might not have noticed before, but can be an indicator of vicarious trauma or burnout. So we really want to be mindful of this, and we want to make sure that we're building protective factors into our practice, especially as you become more aware of using trauma-informed care. That means no matter what, you become more aware of trauma itself. So we want to develop mindful self-awareness. There's this 3 ABCs here acronym. So we want to have awareness of our needs, emotions, and limits. We want to have balance between our work, leisure time, and rest. And if you look at balance as an Indigenous concept, we look into balance between emotional, spiritual, physical, and mental health. And we want to have connection to ourselves, others, and something greater. So something outside of just our work or trauma-informed care. We really need to have connection to other things and other people. And other protective factors found have been active optimism. So, that's like actively trying to reframe your thoughts. Countering isolation, which obviously has been really difficult during COVID. And I think a big reason why burnout is a lot more common. And then that idea of holistic self-care or balance. And what was interesting was that empathetic engagement with patients was found to be sustaining and not a contributor. So if you're feeling kind of these effects of vicarious trauma or burnout, you might begin avoiding patient interaction. But patient interaction, that's when you're empathetically engaging with patients, that can actually be something that protects you from the effects of burnout. I think personally that it has to do with connection to others. So vicarious trauma is something that's real, something just to be aware of. And obviously there's a lot of different resources to reach out and to get help if you're starting to feel the effects of vicarious trauma and burnout. We'll move on to our next section, our last section, kind of talking about these practice traps of trauma-informed care. So trauma-informed care has the potential to, when you're first starting to learn trauma-informed care, even now, I sometimes experience some of these unhelpful behaviors or thoughts. And these are things that we bring to our practice from our own personal experience or a healthcare experience. And sometimes they can be a little difficult to spot. So things to watch out for is attitude about fixing. So this is the belief that you can be helpful enough to fix someone's problems. This actually, though, disempowers the patient because it takes away collaboration. You believe you know how to fix the situation for this person. This subconsciously might be a belief that you can do it all for them. They won't have to do it for themselves. And sometimes I can fall into this trap when I'm really just feeling so so empathetic for someone's situation. I don't want them to have to experience it, but ways to course correct is taking a step back and realizing that a patient's problems are so much bigger than you, and you can only do so much. And even any environment that you work in the inner city especially, you have to realize that medication usually takes up a small portion of somebody's days. There's so many other hours in the day and days in the month where they're not actively thinking about medication or health. And in the inner city, those problems become a lot more serious when it becomes food and housing and basic survival. So realizing that a patient's problems are much bigger than you, and you can only do so much as a pharmacy professional in that moment. And realizing that it is actually more trauma informed to provide as much autonomy as possible, to not limit our patients to one way of solving their problems. And that's another thing. When we look at the next unhelpful kind of behavior, we look at becoming the expert. So this is an attitude where we're talking to a patient instead of talking with a patient. And usually this is an attempt to share all the information. So when I was a student and as a new grad, I find this is a really common tendency for people new in practice, because it's like you've got all this information and you're excited and you want to share all of it to a patient. But we really have to go back to basics so we don't overload our patients and, we don't overwhelm them. There's something called the 3 prime questions. I'm not sure if you've heard about them, but it's this principle where we ask a patient what information that they already know, and then we tailor our response and the information that we give them for each patient. So this goes back to collaboration, where we're collaborating with our patients. We're having a sharing of information of, what does this patient know? What can I offer? And it becomes really a deeper connection of information. Another unhelpful behavior or another unhelpful thought is feeling overwhelmed. I know sometimes it feels like you can't control being overwhelmed. So it's this attitude where you're feeling pressured professionally or personally. I find they often kind of connect to each other. And you feel as if a patient's situation is so complex, you don't know where to start. And this can happen to me often. I have a patient that comes in, say they've got end-stage liver disease. Like, this is a patient that I had recently at the women's shelter. She's got end-stage liver disease. She's got intense mobility needs that can't be met at the shelter, but there's nowhere else for her to go. She's got pain, but she can't take any other medications, because also turns out, she's got chronic kidney disease. And to top it all off, she's like incredibly non-adherent to really these medications that are sustaining her organs. So that is a situation where I was feeling very overwhelmed. And, then you just really have to, again, take a step back. There are all kinds of different techniques for overwhelm, not just in work, but in life, acute relaxation techniques and other things like that. And then we can go back to the idea that we're not there to fix the patient. For that patient, I'm not going to be able to get her into supportive living or fix her end stage, liver and kidney disease, or do her pain management, because, even her gastroenterologist is like, I don't know what we can do. So it's like, I can't fix this patient. I'm just there to be the best pharmacist in that moment. So for that patient, I'm able to encourage adherence in her medications and restart some therapies that may have fell by the wayside. I was able to teach her a way of getting out of bed by using a chair, which is like pretty simple, I guess, like supportive techniques, but something that she didn't know and makes a big difference for her to be able to stay in the shelter that she's at. So really just breaking it down to those little things. What can you do to be, the best pharmacist that you could be in that moment? What can you provide to that patient? And then not necessarily even, for just pharmacists, really any pharmacy professionals or healthcare professionals, like, what can you do for this person in the moment? And I kind of alluded to this a bit earlier about an unhelpful belief that there's only one way to recover. So rigidity. If you are believing that there's only one way to, recover from hypertension, if you're like super, super on the DASH diet or something like that, belief that that's like the best way to work with hypertension. Sometimes that can take away control again from our patients, because we're enforcing our own views about health onto this patient. Ways to course correct for that is just to recognize that we're all different humans. We all have different experiences. We all require different care and healing paths. A common kind of concept for Indigenous people is the idea of a healing journey. We're all on this healing journey, and it looks different for each person. And another unhelpful thought that I also find common too for people who are new to practice is thinking information always creates change. But I find it's a pretty widespread belief. It's this belief that if somebody had all the information, then they would make the change. And sometimes people I find even have this pressure on themselves. So it's like, if only this patient knew how bad smoking was for them, they'd stop smoking. Or like, if this patient knew the risk of blah, blah, blah in, whatever medical condition they have, that they're like not being super adherent to or whatever. It's this idea that like, this person just needs to have more information and they'll change. And we really just need to recognize there are so many more barriers to recovery than just the lack of knowledge. And this is kind of where, if we look at motivational interviewing and how we go back to that principle of collaborating with our patients and empowering them to make their own decisions, we can actually look to see what barriers there are in changing behavior. So what barriers exist, and it's usually not a lack of information, although sometimes that it is, but more often than not, it isn't. And I had one patient again at the women's shelter, and she was really struggling with adherence to her blood pressure medication. And it turned out that because she was at the shelter, they got really strict dosing times, and she's a really transient person. So it's like she was never around at the proper time to take her medications. And, since it was just a blood pressure medication, I was able to let staff know, she can take this medication at any time of day, and we'll see how that works. And then suddenly her adherence is, so much better than it was before from just that barrier. And before I had even tried, being like, well, like, let's look at what your blood pressure measurements are. Well, these are the targets. This is what hypertension is. This is the effects of hypertension. I had even kind of started trying to look for information gaps before realizing there was just this simple time barrier. And the last unhelpful behavior is losing awareness of body language or facial expressions. So actions where you express excessive sympathy or shock can actually have unintended or negative effects on the conversation. This is like, say someone tells you they're trusting you, you're collaborating, and then in those discussions, they share with you like this absolutely like horrific traumatic event, and your face is like, and obviously that person is, that could have a negative effect on that person if, if you might lose some of that safety or trustworthiness that you've built with them by not continuing to have that predictable and stable demeanor. So we're trying to find a balance between an empathetic professional expression, but also an unauthentic expression of self. So for each person, this looks different. But also too, if you have a good relationship with a patient, sometimes you will have different reactions. Some of my patients like that I'm really dramatic. Some of my patients like to joke with me. Some of my patients are like very serious, and I know not to make a joke and like just have like a really straight demeanor. So it's kind of finding the balance for yourself of how you naturally present to all new patients, and then being able to tailor that as you have better relationships. So I just want to kind of go over some closing thoughts. I know there's a lot of different things that kind of go into trauma-informed care. If you're taking anything away from the presentation, really work on that safety and trustworthiness aspect so we don't actively re-traumatize Indigenous patients, because that happens so often. Colonization and colonial practices have created this mass amounts of trauma, and they're still affecting Indigenous people today, and they negatively impact health in multiple domains, if not all. Trauma-informed care is a way of being and acting with patients that we all can do. So it requires us to be trauma aware, to create safe spaces, to cultivate collaboration, and to empower our patients. But also to be, vigilant. We can be susceptible to vicarious trauma and burnout. So make sure you're taking care of yourself and listening to what you need. I know it's easier said than done, but really the idea is you can't take care of anybody if you can't take care of yourself. So sometimes it is helpful to slow down in those moments. And of course, like anything, there's the potential to veer away from the principles of trauma-informed care. Make sure just to occasionally check in and see if you're falling into a practice trap, or maybe if you are having, reactions from patients that can kind of be a sign that you might be into one of those practice traps. Those are ways we can course correct. So I wanted to thank you for listening. I know we have some extra time, so there'll be time for some questions. And then if we have even some extra time after that, there's some different word map activities that we could do. So this question says, how do you approach Western medicine use versus traditional medicine? And what do you think is a good approach to integration? I get asked this question a lot about the use of traditional medicine. And I think maybe it's been, an emphasis has been put on traditional medicine in like too much emphasis, because traditional medicine is often that's something like it's such a sacred knowledge that's only really shared within Indigenous communities and from elders to the younger people in the community or people that need help, the specific medicine people and different specific medicines. And if you actually talk to like old Indigenous people, they're like really secretive about traditional medicine because, they're just like, it's like a really sacred knowledge. So I think like integration of traditional and Western medicine is not so much like pharmacists and pharmacy professionals really want to know about the drugs, right? Like they're like, what are the traditional like medicines, like the drugs that exist? But I find that that's not something that comes up so much as maybe a Western worldview versus a traditional Indigenous worldview. I think the worldviews are more of what's different. How I kind of balance the integration of obviously, having been trained in Western medicine and then also being Indigenous and trying to practice from a more traditional standpoint, the idea of a medicine wheel is really important for me in my practice. If you've never seen a medicine wheel, it's just a wheel split into 4 quadrants. And each of the quadrants kind of represents something different. When we look at healthcare, we think of, healthcare with the medicine wheel is what I keep talking about, the mental, emotional, physical, and spiritual health. And I think that that's a better integration in the sense that we're looking at Western medicine as one part of the medicine wheel. There's so many there's still the, spiritual, emotional, mental approach to integration. And obviously that looks different for each person. I don't think that, you need to adopt a traditional worldview to start practicing with the medicine wheel and everything like that. It can be something like, we just start thinking a bit more for our patients. Well, what is something I can also, do maybe for like, this person's emotional health? And then maybe you start, having pamphlets in your pharmacy or, resources to connect with counselors or something like that. Like just thinking more holistically in terms of healthcare, because Western medicine is often very compartmentalized and very focused on physical health. So I think that's a better integration, because when we start looking at traditional medicine, there's not much knowledge you'll be able to gain as someone who's not Indigenous. Certainly not enough, I feel, that any healthcare professional would be like satisfied with, to be like, yes, like I know now about traditional medicine. Like I don't think any person who's not Indigenous would get to that point. So the medicine wheel and a holistic practice is a much better way to go about it. I hope that answers your question.
All right, I guess we do not have any further questions. That was a very thorough presentation. I just want to say thank you so very, very much for all of the information this evening. And yeah, that was a wonderful presentation. So thank you very much.
Yeah, no worries. And then feel free to forward any questions off to OPA and they can forward them to me if you wanted to connect, and we can definitely go over those things.
Yeah, absolutely. If anyone has any questions, just please email us at education@opatoday.com. And once again, thanks everyone for joining us this evening. Have a wonderful day.
Thank you. Bye.
Bye-bye.